to everybody. Thank you all for joining us. My name is Gray, as probably most of you know me, and welcome to this interRAI International presentation. Before starting, let's acknowledge the traditional owners on the lands on which we all come from and to pay our respects to their elders, past, present and emerging. And we all understand the very important nature of that matter. Today we're very privileged to have Harriet Finne Soveri from talk to us. She has, I know, at least 15 to 20 years of experience in benchmarking in Finland and has done a wonderful job to create a benchmarking infrastructure there based on interRAI systems. So this is really an exemplar of how interRAI can be used to construct a benchmarking capability. Harriet herself is a professor in geriatric medicine and has undertaken quite a lot of roles in policy and practice sense in Finland, and I've known her myself for about 20 years as part of the interRAI establishment. She's the vice president of interRAI, and beyond her interRAI life, I think she'll mind me saying this, she was a soap opera star. Is that a good way to describe it, Harriet? But she's a very well-known personality in Finland, and she was also Woman of the Year for Finland not so long ago. So very, very privileged for us to have her present to us. So Harriet's going to tell us about her journey in creating and using interRAI system to build benchmarking capability. So over to you, Harriet. Thanks so much.
Oh, thank you, Len. Thank you for your kind words. I'm so sorry we cannot see each other. I might be able to see you, but you are not able to see me. I don't know what is wrong with the system, but I'm so happy to be here and I'm so happy to talk to you. And I hope anything I'm going to say will help you forward on your way. Because I must say, after 20 years of really intense interRAI work, I'm still all enthusiastic about everything we have been doing and everything we do. And I'm happy to share some of this with you guys. I'm gonna give you a short glimpse of how we ended up building interRAI into our legislation system. It's quite interesting road because it was the nurses actually who made it and pushed it through. And I'll show you something about that. And then I just have picked a couple of tiny little examples of real life, not research as we usually do, from real life. And then I'm going to say a couple of lessons, tell you about some lessons we learned in our country. I cannot know whether these lessons are usable for you, but maybe there's some help of them. And then what I think, a short summary, and then please just ask whatever you want to ask. Okay. I just need to say a couple of words about Finland because we are up in the north. We are part of the Nordic countries. We have our currency, euro. We are a democracy. And we have been building our elderly care systems, how many? 20 years, 40 years, something, 50 years. And part of our bumpy road has been due to our system. Our democracy is built in such a manner that local authorities really has great deal of power. And just a very short while ago, we had 44 444 independent small areas in this tiny little country. And all these independent areas made their own rules. And therefore, it's not difficult to realize that we really need some common guidelines, and we have help of each other if we are able of building a little bit bigger consortiums. And also, of course, when we started these interRAI systems, this was an international system, and it in the same time when it helped us to build bridges between all these 44 areas, 444 areas, it also opened the door for bigger world, so to say. We are in here, just in case you start to scratch your head, where does this person come from? We are up in the north, and in this picture you see you as well. Okay, our road. What happened? Actually, if you look at the line in the bottom over here, you can see that in the 90s already, myself and my colleague Magnus Björkgren, we started to do our doctoral thesis, our dissertations, and we collected some data using interRAI tools at that time. And in 6 years of study, usual study, nothing bigger, we sort of realized that, hey, here is something that might really help us in our country. And why did we realize that was actually due to the hospital where I used to work at that time. The hospital had approximately 1,000 patients, and the head nurses, they had heard somewhere in the middle of in the beginning of 90s that there exists a system called MDS and RAI and things like that. And they came to talk with me and asked, have you heard anything like that? Would you be interested? Oh, yes, I said. Yeah, I have the system. Actually, I have all these forms in my cupboard. However, it's so complicated that, and you have so much work that I thought maybe it's too heavy for you. And what happened was that they got angry with me and they said, how dare you? Why didn't you ask us? And what happened was that they collected material for my dissertation, for my colleagues' dissertation, and they also talked with people within Helsinki city. This was Helsinki city, in the capital where I was working, in Helsinki city, and got the city nurses, all these long-term care facilities, enthusiastic. Okay. In 2000, we got the national system enthusiastic. At that time, the president of today's Finnish Institute of Health and Welfare, that functions right under this Ministry of Social Welfare and Health. So it's sort of the working tool of the ministry. The THL got interested and said, okay, in 2000, let's make a pilot, let's run for 2 years. And we got 3 towns in the long-term care facilities to start with us. Helsinki, Kokkola, and Porvoo, they are in the different parts of the country. And so we built in 2000 software. That was not a national software, it was a private company, and maybe somebody know RaiSoft software. They built the software together with the nurses in order to make it as user-friendly as possible. I don't have any stocks in RaiSoft or any place else in the software companies, so I don't have any any personal benefit in saying these things. My national institute, public institute, built a benchmarking system, and the idea was that all the data would be put into the software, fed in, and then sent to the THL for analysis, and we produced every half year benchmarking report, and we had seminars. From the beginning, I think we have had several seminars every year. One of the nurses, one of the leaders, and then lately on national level as well, so that all the different levels of care can use the systems. Okay, we started and we thought, well, let's be patient. Let's give them 2 years. Let's not be hasty, because people need to learn the system and learn how to use. Okay. In 2 years, we were not wiser. The nurses were still enthusiastic. They thought that this really helps them to make their case, because they thought that building up the benchmarking and letting out all these reports showed their workload, showed the kind of people they were caring of, their needs, and also the needs the nurses had, of course, because of caring for those people. And they wanted to continue. And actually, Helsinki, as the biggest city, as the capital, the leaders in Helsinki, the high top leaders, thought, this costs money. Maybe we are not interested in this. Maybe we did not get everything we wanted to get, and they wanted to stop it. And what happened in 2003 was actually that the nurses, they said they are going on strike. And Helsinki City took back, and home care joined in 2003. Then mental health pilot, as you can see when you follow the line on the bottom. And then actually the continuing has been sort of getting more and more voluntary users in different parts of Finland. And actually the different parts of Finland have grown to patches, and the patches have merged together. At this moment in 2019, we actually have, from the 20 biggest cities, we had 18 full cities, all the public services, but also the majority of the private services. So that actually we have had quite nice glimpse on several levels on also the public and private possible differences, lots of research. More than 10 dissertations during this time, many local reports, lots of local reports, also lots of national reports. I think we have given out 10 books and things like that. But during all this time, the benchmarking system I'm talking about here, it's based on real work data, where the nurses make at minimum every 6 months an assessment of the persons, of the clients they care for, and they send the data to THL, to the headquarters, and headquarters makes both figures and also tables of the data, and gives them back in couple of months. I think we could be a little bit quicker. We should go towards real time on time system, and there's lots of things in the whole system to be polished. However, the basic system has been good to give the reports and individual reports, so that it's not only the facility, it's always the unit also. Every unit can look at each other. And the whole idea is that within the unit considers whether they are doing good job, whether they want to be examples for the others, and so on and so forth. The other level of this is the seminars, and until the COVID came, the seminars gather nurses from 500 to 1,000 several times per year to discuss with each other, make small group works, and to listen to each other and each other's experiences. And all this in 2019, it has led to several levels of nurses mainly, and nursing home leaders, to use the data for their own purposes, to lead and manage with the help of the data in such a manner that when the ministry asked widely in the country, what should the ministry do to help the long-term care facilities and home care to improve their work, and to help them to lead and build common rules for this scattered country? Okay, we do have a big organizational change in Finland coming. The small areas will merge into bigger patches, into 23 areas. However, the leaders felt that data like this, which is well researched, we have 20 years experience, that is the one we should do all over the place. And what happened was that we do have an Elderly Care Act in Finland since 2012, and there was an amendment to this Elderly Care Act that says that all the interRAI system need to be used in assessments when there's any doubt or hesitation or idea that an elderly person may be needing regular services, which means that you start using them in lighter care patients or clients or residents, in lighter care phase, and then you start using the systems regularly, always when their situation changes uh, during the rest of the life. And here we are. And now I thought I would, after this path, I would go a little bit deeper. And the interesting part is what made the users make up their mind. And I said some of these basic things that has come to my knowledge. We never made really an inquiry what made up the users to make up their mind, but these are the discussions in these seminars, and also the letters and emails that has poured in during all these years. What made them make up their mind? I take first Helsinki, because Helsinki is of course interesting because it's a capital, and also it has been some sort of a leader in quality of care, not the only one, but some sort of a leader in quality of care during all these years. Very enthusiastic nurses, very enthusiastic physicians, my colleagues, and I must say that from the beginning, the sort of readiness to use the instrument, to use the knowledge has been there. And now I show you one picture of Helsinki City Elderly Care patient system, uh, sort of from the point of view of cognition. What is the degree of dementia? Who are we caring for? And when you look at this, you can see on your left side home care, then you see service housing that is public, then you see private, then you see LTCFs, which means that they are a little bit heavier care, um, long-term care facilities, and the payment system between service housing and long-term care facilities is a little bit different, but it's also the same thing, public and private. And the colors here show you from year 2010 to 2015 how the level of dementia has been changing. The green color shows those with a normal cognition. The yellow is in between mild to moderate, and the red one is severe, and then the black one is very severe dementia. And when you follow from left to right in all these services, you can see that there has been some shift, and the shift has to do with the selection, what kind of people we let into these services. But the main point being that most of the people suffer from cognitive impairment and all these other diseases, all these other symptoms, they are attached to the dementia. Also, this picture shows that actually there's not that big a difference between service housing and long-term care facilities. And actually during 2010, Helsinki had four big hospitals only for chronic care. And the big discussion was, is it possible to transform these big chronic care hospitals into nursing homes, long-term care facilities, which could be led by the nurses? And there was very heavy discussions in 1909. And then finally my doorbell rang, and they were knocking at my door and asking, could I provide some knowledge, information based on anything to help them to make the decision? And I said, okay, let's see, let's look at RAI data. interRAI data might show you whether there are differences between nursing homes and the chronic care hospitals, looking at the client's clientele. Are they different after all? They were not. And what happened was that they changed the whole system based on this, and actually the quality of care did not crash, it did improve. And that was really, it was quite striking, and it was on city level change that happened. But this is not the point really totally, whether you can do organizational changes based on some data. The point is more what happens to these people, and that makes my clocks tick and my heart tick. And I show you a little glimpse on one biggest nursing home. It's not one of these hospitals, it's a nursing home in Helsinki. And in 2006, we started a R&D project where we took the RAPs, the clinical protocols embedded into RAI systems, into systematic use. And we started in one house. This is a huge complex with 10 houses. It's the next biggest nursing home in the whole country. It's as big as one of the communities, the local authorities, the smallest local authorities in Finland at that time. So it was in the beginning 1,000 clients and then 650 clients, and we took the RAPs into the use, and the steps were to make the RAI assessment, make the care plan based on RAPs, go every week and look that the care plan really has been fulfilled and everything that has been planned has really happened. And firstly weekly and then monthly, and then the nurses sort of learned where the pitfalls were and what prevented things happening. And then it started running. It was spread to the whole house and then to the other nursing homes. But the point is, if we look at the next picture, this looks incomprehensible probably, but please look at your left side, the table. I'll tell you what it is. This is the table in time point 0, 2006, how the quality indicators embedded in RAI were in that whole house. Then after 5 years after the pilot or this R&D project was over, how the quality indicators had changed in the whole house during 5 years in 650 patients. And all the greens show improvement and the yellow show worse than in time point 0. And then there's a third column over here that says extra in there. That's additional 3 years later. And the deep green color shows whether the quality indicators have still improved from the end. And you can see that majority of these quality indicators really have changed, and the nurses are very proud of this, really. And we also learned a lot of what can be done and what cannot be done. There's a book in Finnish written on this. Unfortunately, it doesn't have an English summary, but since we have a benchmarking system that is going on, we actually do have 20 years follow-up from that particular place. And that's something worth probably publishing also in English, I've been thinking. But being so busy, there are lots of things we're supposed to be doing. Anyways, in this picture, you can see in the lower part also those curves, and they show that actually during this follow-up time, the level of cognition, dementia has not moved really. They are treating approximately the same type of person as in the beginning they did. The colors show that the house where everything started is in the middle. The level of dementia has dropped a little bit, which is quite strange actually, because it has moved to be more and more dementia care unit. However, this house where everything started is the lowest, and the blue curve in here are the benchmarking units, all these nursing homes in Helsinki, how the level in them are, and we can see that the clientele in this place looks a little bit lighter, a little bit less demented, and if you look at the ADL sum, little bit less ADL impaired. However, the selection is same in Helsinki. They come in the same criteria, and the difference between these two curves raises the question, is everybody else doing as much as this place is doing? Interesting, isn't it? I'll show you another example from the same place. I use this place as an example because I wish to be as truthful as possible, and I do know what has been happening in these places, unlike if I'm looking at pure figures in other places. I cannot be sure whether I know all the details in the background, but here I do know all the details in background. Okay, what we see here is the beginning of the benchmarking in this place, and you can see pressure ulcers in here. When we started 2000, in the beginning of actually 2001, we started, and the data was collected spring 2002. The common knowledge in that place was we don't have pressure ulcers at all. And it was really a shock to find out that actually the pressure ulcers were over 8% of the whole house. And then we started doing different improvements with mattresses, with pressure relieving systems, with anything you can think of. And when we collected next data, the pressure ulcers were 14%. And everybody who has been doing systematic quality work knows that this is a certain bias. Anyways, when you look at these figures, you can see that lowermost in each column is first grade pressure ulcer. Then the violet part, purple part, already shows that the skin surface is broken, and then upwards you get heavier grade pressure ulcers. Anyway, then in 1.5 years, no real improvement happened. And then in 2004, there was a nutrition program. My colleague was doing running a nutritional research, and we started a program in that place. And look what happens. From 2004 to 2005, the pressure ulcers, they just crush. Then when we go further in 2006, this is not nutrition programs. I'm sorry, I didn't change the title. The loss of labor starts. We had lack of labor due to different things, and the pressure ulcers popped up again. But thanks to the systematic assessments, we realized it immediately. And as you can see, the quality did not worsen very much, and we managed to get almost to the same level as in 2005. And the lesson learned here was that don't look at one thing at one time. The truth is much more complicated than one issue truth, one topic truth. You should see, exactly as geriatric laws say, you should have comprehensive geriatric assessment with comprehensive view on the client. And there are several things that always matter. This is the lesson we learned here. And actually, if I collect a little bit together, what make the users make up their mind, it came from several levels. It came from the knowledge. That was the most important thing. I know what kind of persons I'm caring for. Then it came for experience. When I move this, what is changed? Is something changing? Or am I doing non-necessary efforts? Am I doing useful efforts? And accumulating expertise. Expertise is probably, I know what I'm doing. I know what I want to plan. I know where I want to hit. And in this world where everything is not gainable, we cannot get all the resources we want. We cannot get all the nice things we would like to give to these older persons. We need to choose. And this helps us to choose. Well, what was the benchmarking made of? Let us see. It's quite simple. We firstly we put up 3 types of comparisons, and the most important thing is to show your clientele all these measures, all these functional figures, all these social life figures, all these mental health figures, to show what kind of their life is from the point of view of professionals. Then we put up quality indicators, and then we put up also some individual items from the assessments. And the comparisons were always made. The nurses looked at their own unit, their own clients, their own patients, and compared them with time. So they could see whether in our unit our clients get worse or better, if we get new clients, are heavier care patients, or are they approximately the same as they have been. That was one thing, to follow up your own performance in time in all these levels, quality indicators and case mix. Then to see whether the own unit can see whether you are treating heavier care patients than your fellow units in the same organization, and whether your quality is better or worse than in your fellow organizations, in your fellow units in the same organization where you work. And then finally, to be able to compare all these things against national figures, national means, and national guidelines, also thinking about whether you have a sort of a goal somewhere and you try to reach these quality goals or things like that. So basically this, and there are several types to make figures out of them. You might get sort of a radar plots, you might get other types of things, but the knowledge embedded into them is the key point. It's here. And then comes the whole thing what we learn from each other, and the whole area and platform of discussing the things that really interest me and my unit, and what are the similar units, because I'm able to sort of find out who in this whole country is treating similar patients as we are, similar clients, and what kind of ideas they do have, and sharing these ideas. Then also I want to say a couple of words of regulatory systems, because regulatory systems in our country are moving towards own follow up, own monitoring, all these units, both in long-term care facilities, hospitals, in home care. They should produce sort of regulatory reports themselves and follow up their quality, and it's pretty much work. And one of the biggest things has been that if they go and fill up forms for some regulatory organ, every minute is a way of the work they should be doing with the clients. And now when these data and information can be taken from the interRAI assessments, the nurses don't need to do extra work. And also these THL reports, national reports, can serve. However, THL don't send the regulatory organs any reports without the permission of the facility. So it's always the facility can give permission to show the reports to the regulation. Then finally, I'm starting to finish now, and finally, I said in the beginning a tiny little word about opening the windows to the world. And one window has been European Union financed research systems, and we have had several projects. This picture is from the oldest project, our ad hoc project that was performed in 11 European countries, RAI project, and then our not next but third project, I guess, that was performed in 8 European countries in long-term care facilities and Israel. And this is a small sort of candy from the ADLs and cognition from all these countries in different in different time points. A little bit, there are 5 years in between, but if you look at these sort of collections of small dots, you can see that in the below, nearer to the 0 point of the cognitive axis and the ADL axis, which means that the means of the clients are lighter care. So they are all collected near to the 0 point in home care. This is home care project. And then there's always a gap, almost a gap between the other collection of the points that is farther away from the zeros. And that shows how much how the means of the ADLs and cognition measures are heavier in the long-term care facilities compared to the home care. And then you might ask, okay, first you might comment, it's pretty similar though in each of these countries. They are similar in European countries, but not quite. In the home care, Deutschland, Germany, seems to be treating heavier care patients at home than the rest of Europe. That is what it shows. And then when you look at the upper part, you can see that there are some differences between countries. Finland is in the middle quite a lot. Italy and France are a little bit heavier care. Same applies to Israel. However, there's a gap in between, and this is my question: where are all these peoples who belong to this gap? Do we have some kind of system that is missing in here, or what is the question? We can discuss this if you want. Anyways, here is some data if you want to look closer to these pictures. Anyways, this was it, and now I would like to summarize here. I hope you are all awake and you had possibility really to listen. When I'm summarizing the benchmarking, I'm summarizing it as a necessity. We need desperately ways of binding together lower level decision making, and here I mean lower level decision making. I mean decisions that apply to the client, decisions that apply to the units that are serving to the clients, and the middle management decision making and national decision making. And benchmarking offers a great possibility of doing that, looking at the case mix and looking at the quality. This is one thing. The other thing is that we desperately also need some sort of a platform where all different professionals talk with each other. And now when you have listened to my presentation, you have noticed certainly that I have been talking a lot about nurses and quite a little about physicians. And actually, we have in our country more than a fistful, but I'm saying more than a fistful of really capable physicians that has adapted the system and started leading. The city of Tampere is a great example of that. Their leading physician is just a wizard using all these interRAI data. However, we have not put a lot of effort in educating physicians into RAI systems. We have more thought that the nurses sort of offer information that is clear and reliable for them to use for decision making, and therefore some of the physicians they do participate. They make sure that the diagnoses are right. They see that the medications are right. Physiotherapists take care of all these rehabilitation parts and improvements and also about balance and these sort of things. They participate that way. However, this is a marvelous platform to discuss the patient's needs together under the umbrella of comprehensive geriatric assessment. And now when the legislation has come, the physicians start waking up, and last week we had the whole central Finland a presentation where we looked at the patient cases from the physician's point of view, and I think this is our next step, and also making the feedback reports closer and closer up to date, so that the delivery time shrinks from 2 months to maybe 2 weeks or something like that. So this is where we are. Is anybody awake there?
Well, I'm awake, Harriet, so you'd be pleased to hear that at least. I'm sure others are. So it's been a really interesting journey. This is what in interRAI speak we call largely a bottom-up kind of approach, getting the providers really to drive the use of the betterment of care, which is the kind of driving philosophy we have here in Australia. Although we do understand that governments need to at least facilitate or enable this kind of activity to occur. So, does anyone have questions? Murray, I think it's got to be on chat, does it, or can we?
If people would like to raise their hands, I can take them off mute and they can ask the question live. That's probably quicker than chat.
Okay, let's do that. Can anybody want to comment or ask something? While you think, oh, here we go.
Cedar's coming on. Cedar, if you just like to introduce yourself quickly.
Hi, yeah, good afternoon. Sorry, my name is Cedar Ian. I'm working for a provider called Cathay Healthcare. So I manage our clinical systems. So I've been with the project for a few months now. Thank you, Harriet, for the good story from Finland. My question is just around, I saw a number of analysis in there is sort of having a granularity that over a number of years. So just, but I guess from my personal experience, often we will look at our data at a much more frequent time interval. So, you know, monthly, even sometimes fortnightly or weekly. So do you see interRAI system would work from that perspective, the time granularity?
Well, in our country so far, we have collected the data actually only every 6 months, which is quite seldom really. And what I'm seeing a possibility also to move on more regular intervals and more rapid intervals, and that will provide us also maybe weekly, maybe monthly possibilities in intervening. However, if I'm looking forward, I think this is exactly the way we should go. We should go to more rapid partial assessments on the areas that change, and then sort of following them, and time to time do the total whole assessments. I think this is the way, because now what we do in our country is that we if we want to have physicians involved, the best way of involving physicians is always freshly after the assessment has been done, and therefore you can spread the whole field in such a way that that every patient in the facility does not come to the physician in the same day, but they are spread over the time, and this is what people do nowadays. However, I'm not sure whether we can come in the long-term care to the, or whether there's any point in coming daily assessments or anything like that. The changes are not that type. However, at least quarterly assessments, yes. Maybe some patients, some clients more often, and but it depends, Cedar. It depends. How you assess your patients, whether you have spread it over time or whether you have everybody in one rush. How is it?
I think the assessment process should be almost like a constant. So the continuum of care, we constantly reassess people, and if there's a detection of change, obviously we will update our assessment. So but I agree with your point on the frequency of using the data. I think it should be used more frequently. Every 6 months to me, like I'll probably understand at a national level, the data collection process probably is not as flexible as just doing something internally in an organization. So we would probably do monthly at least, in terms of looking at the data and how to drive our decisions based on it. But yeah,
okay.
thank you.
Yeah, and I just add that if you look at the R&D project we had in one of these nursing homes, that is a good example how the data lives when you take the wraps or caps of all these assisting protocols that interRAI has, and you really embed them to the care plans, then you sort of keep on visiting these things all the time, actually every day, even though you don't change the assessment every day, but you visit the issues every day. And that keeps the key points in the client's work with the client on the up-to-date level all the time. Yeah. Thanks, Dean. Thanks. I see your picture.
Hi, Harriet. There's some. Chongi has asked a question.
It's Chongi. That's right. Hi. Yeah.
My name is Chongi. I'm actually in a community and aged care provider in Perth. I'm just curious about finding out, was there a lot of home care providers or users in Finland of interRAI? Because it looks like there's a skew towards more residential care in terms of compiling the data.
Well, yes, thank you. That's a good question. Of course, I did not provide you all the data about the magnitudes of the different assessment system types. And actually, the point is that home care is the bigger one in our country.
Did my question got through, or I have here?
We have something like in our country, 75% of the assessments come from home care now, and 25% come from long-term care facilities. I took these examples, as I said, really selfishly from the places I know from inside, that I do know that the changes that happened are true. And it's not something about selection or something else. I know they are true, and that's why I picked them from long-term care facilities. However, in our country, long-term care is something like 40,000, and home care is something like 70,000 regular base, and then there's irregular base, altogether 140,000. And the proportion today is about the same proportion as we have. When you are asking about quality improvement, we actually do have some publications also in Finland, only this in English in Finland, unfortunately only the summary, but we have looked the whole areas of home care, what happened when one city change the physician's work in such a manner that a physician who knew the home care patients was available 24/7. She was, or he was not available for the clients, but he or she was available for the workers. And what happened during that change was that all the queues for long-term care facilities crashed down, and the city, small city, saved €1 million during that year. The quality of care improved in some manners and some manners not, but the city was able to care for dementia patients, more severe dementia patients at home when these changes were made, and interRAI tools made it visible. Does this answer any to your question?
Yeah, that's really good. It's probably you hits the mark.
Yeah. Thanks for those questions. I think it's an hour, well after. We could probably talk to Harriet for quite some time, but it's been very interesting, Harriet, to hear. I've heard some of this story before, of course, but
Sure.
quite a journey, and very successful along the way, and getting more successful as I see it. So probably time to let Harriet go and have a coffee and some breakfast, and we might think about what we're going to do being later on Friday afternoon.